Talk about metabolic acidosis. And metabolic acidosis happens because of a bicarbonate deficit in the acid-base balance. Remember that 20-to-1 ratio. And if there is a loss of bicarb, this can disrupt that ratio. Also, if there is an excess of acid in the body, this can also disrupt that ratio. So let's take a look at our metabolic acidosis model. Remember that if we have that homeostasis, our normal pH is going to be 7.35 to 7.45. And any disruption within that is going to cause an increase in hydrogen ion production, or it could be that our body is decreasing the hydrogen ion excretion, or we're losing that bicarb. So we have this excess production and we have a decrease in the loss of that hydrogen ion, which is going to result with acidity. And when we are acidic, our pH is going to fall to less than 7.35. So we'll also see that our bicarb is going to fall and it's going to be less than 22. Our body is going to try to activate that buffering system, and it's going to allow any of those molecules that are buffers to accept those excess hydrogens, but remember, it can only go so far. And the respiratory system is also going to be activated, increasing the rate and the depth of our respirations in an attempt to try to expel or eliminate that extra CO2 that's causing that carbonic acid. If our kidneys are functioning properly, then it will start working to excrete some of those excess hydrogens as well as produce that bicarb to help return our pH back to that normal range. So if we drop down really low, it's going to start, all these corrections are going to hopefully increase our pH back to a normal range of 7.35 to 7.45. So metabolic acidosis occurs when an acid or other carbonic acid accumulates in the body, or when bicarbonate is lost in our bodily fluids. So think about keto acid from ketoacidosis, that type 1 diabetic. They're at extreme risk because remember, our cells need glucose for energy, and when there is a lack of insulin, the glucose cannot get into the cells, so the cell begins to use fats and proteins, which when they're broken down, release those ketones and acids. So there's too much of an acid in the body. Lactic acid is going to be accumulated as a result from tissue hypoxia due to shock or cardiac arrest, and what happens is they're produced by lactate and hydrogen ions that are combined from anaerobic metabolism. So that means when things are metabolized without oxygen. So when the cell is not getting enough oxygen, this is when that lactic acid can accumulate. Severe diarrhea, and this is because our body is going to be getting rid of any of the bicarb that was produced in the gut after digestion. Intestinal suctioning, or like when we have an ileostomy or something like that, even fistulas, they can lose some of that bicarbonate because the pancreas in the small intestine has released that bicarbonate-rich fluid to help neutralize that hydrochloric acid that's entering into the small intestine from the stomach. And remember that hydrochloric acid is in the stomach to help break down foods. So once that it reached that small intestine, that bicarbonate is now mixing with it to help neutralize all of that as it passes through the gut. So when we have an ileostomy or a fistula, it contains all of that bicarb that our body has. So So severe loss from the GI tract can result in acidosis. Also, if we have acute or chronic kidney disease, this can cause the kidneys to lose their ability to actually excrete or expel some of those hydrogen ions, as well as their ability to reabsorb or produce bicarbonate. So when a patient has any kind of kidney disease, we need to be looking at their ability to get rid of the acid as well as produce that bicarbonate. So another one that your book doesn't really talk about, but I want to let you guys know about because it's something that we need to be aware of, is that if a patient is given solutions that have high amounts of chloride, they can also develop hyperchloremic acidosis from all this excess chloride. And so that can actually be too much acid, which is in the body. So to compensate, the compensatory mechanisms are going to kick in for metabolic acidosis, and that's going to be our kidneys attempting to excrete additional acid and the lungs increasing that CO2 excretion or expelling that CO2. The patient often is going to develop those Q-small respirations, that deep rapid breathing like we've talked about with DKA. So what happens is the respirations will increase in both the rate and the depth as the severity of that acidosis increases. And the medical term we use is that Q-small respirations. And this is typically going to happen and be associated with severe metabolic acidosis like in DKA. And remember, in DKA, we need to treat the underlying cause in order to correct the breathing. So our focus is going to be on correcting the fluid imbalance and the hyperglycemia by treating it with insulin and fluids rather than treating the breathing. So we may still have to help with our patients' breathing techniques, helping them try to focus and slow down their breathing. But remember, there's a physiological component to DKA where we have an increased glucose, and we need that insulin and those fluid imbalances that we have to actually correct that are causing that Q-small respiration. So as we correct or reverse the physiological things that are going on, we will see a correction in the respiratory as well. If the kidneys are not the cause of the increased acidosis, like in DKA, they're going to try to compensate by excreting some extra acids. But in kidney disease, we find that the kidneys are not able to excrete that acid, and they're not able to make enough bicarbonate. So we see metabolic acidosis in a lot of chronic kidney disease. So you may be wondering how in the world we're going to tell the difference between an acid gain in the body or a bicarbonate loss, since we know that that's what actually causes this metabolic acidosis. And this is where an anion gap comes into play. And what this is it's a formula that's going to calculate the difference between serum cations and anions. And if you remember back to our fluid and electrolytes discussion, you're going to remember that sodium was the major cation in the extracellular fluid. So it's the positively charged cation. And bicarb and chloride are the major anions. So they are negatively charged within the extracellular fluid. So the anion gap is simply the difference between these two, the serum anion and the serum cation. So if metabolic acidosis is present, we can calculate this anion gap to help determine, was the source from an added or excess gain of acid, or was it because of a loss of bicarb? Now, when you calculate this, what we're going to do is we're going to take the sodium and we're going to which is the cation, and we're going to subtract both the bicarb and chloride. And the reason that we combine the bicarb and the chloride is because those two levels actually combined are what kind of make up that same they create that neutrality for the positive cation. So we know that sodium was that positive cation. It takes both chloride and bicarbonate together to neutralize that sodium or that positive charge, because our bicarb and our chloride are both negatively charged. So when we add those two together and subtract it from our sodium, that's going to tell us what our anion gap is. And a normal range is going to be from 8 to 12 millimoles per liter. So now when we see an increase, so above 12, we know that we have gained acid. So we may have a normal bicarb or a normal chloride, but we or even lower than, just slightly lower than normal, because of these acids that are in the body, because the acids are usually negatively charged. But what we're going to see is that this is going to increase that anion gap. So it's going to be above 12. We know that we've had this acid gain. But if it's normal, if we have that 8 to 12, then we know it's because of a bicarbonate loss, like in diarrhea. And the reason that we can see the difference between these two is because anytime our bicarb decreases, our chloride typically increases, and so it doesn't change that gap because the anion of chloride is actually increasing as our bicarb decreases. There's no change in that anion gap because there's no change between the amount of sodium to the ratio of chloride and bicarbonate. Now we will see that the bicarbonate drops, but that chloride has gone up. So this is also, again, if you remember back just a slide ago when I said hyperchloremia can also affect it, and that's because if the chloride is too high, then we have other issues. So how are we going to diagnose metabolic acidosis or a metabolic acidotic state? This is going to be determined, number one, by our ABGs. So we know that we have acidosis just based on what our ABGs are telling us. But we also need to figure out what that underlying cause and what the reason for that state is, and we need to diagnose that. And that's where we're going to start looking into some other things. This is when we need to look at our electrolyte imbalances that might be present. We need to be calculating that anion gap to tell us, do we have an acid gain or is there something else going on? We may see hyperkalemia as well as hypomagnesium that are also electrolyte imbalances that are going to be associated with metabolic acidosis. We need to make sure that we are assessing our ECGs, and this is because, think back to hyperkalemia, if that's going to be present, then we need to understand the severity of that imbalance, and this is where our ECGs, because of dysrhythmias, start coming into play. We're going to check blood sugars or blood glucose levels, and that's because, remember, in DKA we have a high blood glucose level, and this could result with metabolic acidosis because, again, the body is breaking down those fats and proteins because it can't get that glucose into the cells to use it. So we have this excess of acid because of a high glucose. We'll do renal function tests like serum creatinine or BUN, and this is just going to assess whether or not the body is actually able to get rid of those acids, as well as is it able to make that extra bicarbonate needed in this state. So some key assessments that we're going to be looking for. We may have anorexia or a lack of desire to eat, and this could occur because of any kind of diarrhea, or if we've got any kind of gastrointestinal function that's going to be affected, we may see a patient that has anorexia. The abdominal pain, this could be from the diarrhea, it could be from fluid imbalances or an ingestion of some kind of medication or toxin that has excess acid in it. Think about aspirin, methanol, ethanol, any of those may have an excess of acid that could cause some abdominal cramping. Our weakness and fatigue, this is typically going to be due to that decrease in tissue perfusion. And remember, with hyperkalemia, we've already talked about those dysrhythmias and not being able to get the blood where it needs to go, so we've got a decrease in our tissue perfusion. This can also result in a decreased level of consciousness because we're not getting enough blood to the brain. So our dysrhythmias, like I just said, they need to be monitored because of the metabolic acidosis, and especially that cardiac output is going to be affected, so it decreases the heart's ability to contract and can cause that bradycardia. And so we have that super high risk with any type of potassium imbalance. So we need to pay attention to that. Then with our respiratory center trying to compensate, we're going to have those Kussmaul respirations, or that labored deep breathing like we were talking about a minute ago. So those are key assessment factors when it comes to metabolic acidosis. And remember, that's because our body is trying to blow off that CO2. So how are we going to treat it? Remember that most of our medications are going to depend on that underlying cause of metabolic acidosis. For example, when we have that DKA, we're going to correct that high blood sugar by giving our patients fluid and insulin. as well as monitoring their heart to see if there's a shift in that potassium back into the cell, and we may have to supplement that potassium. If our underlying cause is a fever or diarrhea, then we're going to be giving antipyretics and anti-diarrhea medications to correct that imbalance or that what's going on physiologically. If renal failure is the cause, then our patient may have to take some type of oral bicarbonate simply because their body's not able to produce that bicarbonate. But in severe acidosis, we may have to give IV bicarbonate. And if we give any type of IV bicarbonate, we need to monitor that closely, because what can happen is we can end up with some fluid overload. So we've also got all these electrolytes that are going to be imbalanced, so we need to monitor any of our serum electrolytes and replace those as needed. And like I just said, with that bicarbonate, if we're giving it, we could have these fluid shifts. And so when those fluid shifts happen, we need to correct them. We may have to correct not only the fluid, but also the sodium that may be affected as well. So we need to monitor those very, very closely, and especially for fluid overload. The next thing that we're going to do for treatment is we need to make sure we are teaching our patients. If they are at risk, have any diagnosis that puts them at risk for metabolic acidosis, this is going to be huge. We need to teach our type 1 diabetics, our patients with liver cirrhosis or any other endocrine disorder about the signs and symptoms that they can catch that metabolic acidosis quickly, because if we can teach them to recognize these early signs and educate them on the importance of following their treatment plans based on their diagnosis, we can avoid some of those severe complications that are associated with metabolic acidosis. So hopefully we can teach them to recognize that acidosis so that they're not getting to the dysrhythmias or the loss of consciousness and those types of things. We can prevent the seizures or the coma. So we want to teach them how to recognize those early on. Now, let's review metabolic acidosis real quick, going back over all of this. So remember, it's an issue on the molecular or cellular level, and this is because of an accumulation of metabolic acids or excess of acids plus excessive loss of bicarbonate. It can also be due to an increase in that chloride level. Remember that we said it could be from acute diarrhea or any of those intestinal suctionings or ileostomy drainage. It could be from DKA. So in metabolic acidosis, the pH will be low. So it's going to be less than 7.35. Our PCO2 is going to be within normal range because it's not a respiratory issue, it's a metabolic issue. So respiratory will be within that normal range. And then our bicarb is going to be low as well. So it's going to be less than 22. So when we're thinking about that model of Rome, we're to the M and the E. The M stands for metabolic because we know it's a metabolic issue, and E means that the pH and the bicarb are equally going to decrease. So that means that we're going to see our pH is low, so is our bicarb. So because our bicarb is that metabolic indicator. When our patients are compensating, remember that our lungs are going to compensate a lot quicker than our kidneys were. So our respiratory system is going to begin to work faster and help compensate for this acidosis. And it's going to increase those respirations. We may see that Kussmaul breathing to blow off that CO2 and get the the blood level of CO2 back within range. So we were trying to drop that CO2 to bring that ratio of 20 to 1 back into, and that's that acid and bicarbonate ratio that we've talked about, to bring it back into balance so that our pH can return to normal. So if we are compensated, our pH is going to be 7.35 to 7.45, which is normal. Our PCO2 is now going to drop because we've blown off all this extra CO2, as well as our bicarb is also low. And this is because that's where it started. It started with our bicarb already being low. Now, just like in any of the other imbalances, we're going to have partial compensation, and this is when we're going to see that our pH is almost back to normal range, but it's not quite there yet. But we may see that we already have decreased levels in our PCO2 as well as decreased levels in our bicarb. And so that would be partially compensated metabolic acidosis. And remember, we're going to look at our anion gap to tell whether or not it was a bicarb loss that originally happened, or if it was that acid gain. So if it's a bicarb loss, it's still going to be between 8 and 12, that anion gap. If it was an acid gain, then we're going to see an increase above 12 in our anion gap, and that's going to indicate that we need to treat it and try to get rid of that excess acid. So we will be working some of these problems again in that Blackboard Collaborate. So just keep any questions that you have, let me know about those, and we'll try to get those answered in our live session as well.